Hi guys, welcome to my YouTube channel. I hope you all are doing very well. I am Dr. R.K. Modi, Director of Modi General Hospital and ICCU. I am also attached to Fortis Hospital, Mulund West, Sushrusha Hospital, Vikroli East, and I am also attached as a honorary physician to a municipal hospital. Today I would like to talk about Covid-19 and coagulopathy. I am going to start my video. Let's get started. I am Dr. Modi. I am a senior consultant physician practicing in Mumbai for the last several years, attached to various corporate hospitals and municipal hospitals. I worked in many Covid-19 places. Now, I like to talk to you today regarding this topic, Covid-19 and coagulopathy. You all might have heard a lot of lectures regarding Covid-19, the treatment, the symptoms, the signs. But today we have chosen another topic, that is coagulopathy. Why I have chosen this topic is because I have seen many patients, the mortality is due to the thrombosis in multiple organs of the patients of COVID-19 who are in the moderate or severe crisis state. So this topic is very important in a COVID-19 patient. So let us now start our program today for this COVID-19 and coagulopathy, where we can start with what is the COVID virus, 19 virus, and what is the mechanism by which you get the thrombosis or clots in the blood vessels, and what are the complications due to this, and what is the proof that there is a thrombus in the blood vessels of these patients who are COVID-19, and the treatment, and what is the latest treatment which has come in May 2021. So let us start. Now, COVID-19 is caused by an SARS-CoV-2 virus. It is a highly transmissible and pathogenic coronavirus. It is causing the current epidemic and affecting billions of people worldwide. SARS-CoV-2 infection is frequently asymptomatic, but 20% of the patients, they require admission to a hospital. COVID-19 associated hypercoagulability has gained huge interest, and a large number of clinical trials were aimed at improving the outcomes with anti-thrombotic therapy, and these have already started. Now, out of this, we like to know how the thrombus is formed inside the blood vessels of COVID-19 patients. Various studies have been conducted. One study says that the virus attacks the endothelial cells of the lining of the blood vessels. It then binds to the ACE2 receptors, which is in the endothelial wall. This ACE2 receptors in the pathogen of COVID-19 is not known. Yet it is shown that once this virus attaches to the ACE2 receptors, a protein is released, and as a result of this, in fact, down-regulates the ACE2 and worsens the lung injury that is reversed by treatment with angiotensin receptor blocker mediated up-regulation of ACE2 expression, thus regulating production of angiotensin 2 and concomitant enhancement of IL-6. IL-6 is actually inflammatory marker, and this IL-6 activates the H2 enhancing angiotensin 2, leading in angiotensin 2 retention, leading to endothelial activity and inflammation. Now I'll show you the pathway Actually, it's a little bit of complicated when you see this, how it is formed, but you can see the coagulation pathway. Uh, First, what happens is the virus enters into the body, it reaches the endothelial cells or endothelial wall of the blood vessel. Once it goes to the endothelial wall, it attaches to the ACE2 receptor, which is available in the endothelial wall. Once it attaches to the ACE2 receptor, there is a trigger of production of angiotensin 2. This angiotensin 2 increases the IL-6 level. The IL-6 level later inactivates the ACE2 receptor, resulting in production of angiotensin 2 again and resulting in activation of the endothelial wall, producing inflammation of the endothelial wall. Later, there is aggregation of monocytes, infiltration, complement activation, and the plasma high cytokine, leading to endothelial injury, thus resulting in coagulation of the vessel. So this is one of the uh, pathways which I have shown you. Other pathways are also there, like neutrophil activation pathway leading to thrombosis. And these pathways, you can see that slide is shown to you how the virus enters into the body, producing myeloperoxidase, neutrophil elastase, chromatin content, leading to endothelial injury and coagulation. Now, once we have seen that in COVID-19 infection caused by SARS-CoV-2 RNA virus, where it attacks the endothelial cells or endothelial wall of the blood vessel, attaches to the ACE2 receptor, producing angiotensin 2, later stimulating and triggering the release of pro-inflammatory marker like IL-6, where both together result in endothelial injury, aggregation of monocytes, complement activation, cytokine activation, resulting in endothelial injury, clot formation. Okay, so we have seen all this, and now when a patient who is more predisposed to these formation of coagulation disturbances in a COVID-19 patient. So let us see who are the which are the contributing factors. One is people who are more than 60 years, those who are obese, those who have diabetes, hypertension, those who are pregnant, those who have cancer, those who have prolonged bed rest, those who are undergoing surgery, those who have habit of smoking, and those who have deep vein thrombosis, or females taking oral contraceptives. Now these oral contraceptives, so these are the people who, if they get COVID-19 infection, they are more prone, leading to moderate or severe complication and leading to thrombosis. Now, we have now discussed that in COVID-19, the mortality is due to the blood clots in the blood vessels of the body. Now, what is the proof that there is blood clots? This is just a theory and studies which is conducted. So, in 2020, a study was conducted in COVID-19 patients who expired. An autopsy was done by Mr. Ackerman, and he found that the lungs of COVID-19 patients in autopsy had numerous blood clots in the tiny vessels of the lung in autopsy in 11 patients. So he done the autopsy of the 11 patients who have expired due to COVID-19, especially those patients who were moderate or in critical state, and he found a lot of blood clots in the tiny vessels of the lung. All of them had various degrees of blood clots, but they never received a diagnosis of blood clot when they were alive. Hence, he felt that this virtuous triad fits into these patients. That is, virtuous triad says there is endothelial injury and there is stasis of the circulation, and along with it, there is hypercoagulation of the blood. And these three together results in blood clot. So now we have proof. We have proof that there is blood clots and clotting takes place in COVID-19 patients. So this is a proof. Now, suppose if the body, various sites of the body, this clot formation takes place, what will be the complications? Suppose the blood clot is formed in the brain, in the cerebral vessels. The patient can have stroke following COVID-19 infection. In the heart, it can block the coronary arteries, leading to myocardial infarct. In the kidney, it can cause acute kidney injury and renal ischemia. The veins of the lower leg, if it gets blocked, it can cause deep vein thrombosis. And in the lung, it can cause pulmonary infarct and pulmonary thromboembolism. So once we have studied now that till now that what are the complications to other parts of the body and other organs when you get a coagulation disorder and a formation of clot. So now there was a study. We like to know the symptoms of the patient and the coagulation markers. By seeing the symptoms, we can know, and the coagulation markers by comparison, we'll come to a conclusion which patient is predisposed to formation of clot. So we will start that now. We have decided the symptoms of the patient in COVID-19. We have decided that we will separate it into three stages. Stage 1, stage 2, and stage 3 according to the symptoms of the patient of COVID-19. Stage 1. Stage 1 are the patients who are ambulant or admitted to a hospital because of some other reason and not for COVID-19. The symptoms are mild. They don't need any respiratory support. Inflammatory reaction is very minimal. The coagulation markers, the D-dimer, see coagulation markers which was being compared in this cases were the D-dimer, the fibrinogen level, the prothrombin time, and the platelet count. Here the D-dimer was 2 to 3 times upper limit of normal. The fibrinogen level was normal. Prothrombin time was normal. And the platelet count also was normal. Now, what are the thrombotic events that took place in stage 1 patients? Limited pulmonary inflammatory microthrombi. Now we'll go to the stage 2 people. Who are the stage 2 people? Stage 2 people who are admitted to a hospital and they need oxygen supply. Their symptoms are very severe. They need respiratory support. Their inflammatory reaction is very pronounced. And here the coagulation markers, when we found out in this stage 2 patients, we found that the D-dimer is around 3 to 6 times the upper limit of normal. Fibrinogen was mildly increased. The prothrombin time was mildly increased. The platelet count was also low. And what are the thrombotic events which took place in these patients? There was increased incidence of inflammatory microthrombi and macrothrombi. So these were the stage 2 people. Now, who are the people who are in stage 3, where we have changed them? In stage 3, these are the critically ill patients. They are always in need of organ support. Their symptoms are very critically ill. They need organ support with high flow oxygen, HFO, or they are on mechanical ventilator support. Here the inflammatory reaction is a cytokine storm. The coagulation markers are very much prolonged. D-dimer is 6 times the upper limit of normal. The fibrinogen is also elevated and increased. the prothrombin time is markedly increased, the platelet count is also very low, and the thrombotic events shows there is high incidence of micro and macro thrombi. So we have studied the symptoms and the inflammatory markers. Now, what happens if the patient is discharged? When the patient is discharged from the hospital, then the symptoms are he is recovering. There is always some functional limitations in his activity. Those patients, especially those who are critically ill patients, they recovered and want to home. Here, they are actually mostly a bedridden, or there are limitations in their activities, and that will remain at least for about 3 months after discharge. The inflammatory reaction is restored, the coagulation markers are also restored, and the thrombotic events, they are also unknown. So now we have studied all the three stages, okay? Stage 1, stage 2, stage 3. Stage 1 people we have studied, their coagulation markers are not that much deranged, and stage 2 people, they are deranged, and stage 3 critical patients, they are highly deranged, and the coagulation markers we have to test it in these three people in stages are fibrinogen, prothrombin time, APTT, and the platelet count. Okay, so now after knowing and comparing these symptoms and the investigations which we are doing, what are the lab investigations which you can do when a patient comes to you with COVID-19 infection? Those who are asymptomatic, we can do the CBC, the RFT, the LFT, random blood sugar, and an ECG. Those who are symptomatic, same investigation, you can add an X-ray chest along with it, and you can do the SpO2 monitoring with a pulse oximeter. And 3, symptomatic patients who has upper respiratory tract infection, you do the same investigation. To that, you can add the CRP level, LDH level, D-dimer, serum triglycerides. These can be added to the routine investigations for COVID-19. Suppose there is a patient with pneumonia and he has got without any respiratory failure. Again, the same investigations you can continue, and those patients who are in respiratory failure, all the above investigation plus you can do a CPK-MB, and you can get the tropi, and those patients who are with in shock state with respiratory failure, you can do the blood culture. So these are the routine investigations in a COVID-19 patient who comes to you as per the symptoms and as per the stages, clinical stages. Now, what I feel is every patient who comes to you, if he is admitted in a hospital and if he is having moderate to severe clinical symptoms, then these investigations, which is routinely done, along with it, I prefer to add the following investigations to these patients so that we can come to know what are the parameters, coagulation parameters, which is abnormal. One is fibrinogen level, one is FDP level, third is INRPT, APTT level, fourth is antithrombin level, and the fifth is antiphospholipid antibody level, which consists of lupus, anticoagulant, and anticardiolipin antibody level. Now, let us see why we have to do all this. Fibrinogen level. Fibrinogen level, the normal value is around 200 to 400 milligram per deciliter. If the fibrinogen level is high, that means the increased risk of thrombosis. FDP level, when the endothelial injury heals and the blood clot is broken down by the plasmin, then what happens? These broken fibrins, these fragments we call it as FDP, fibrinogen degradation product. If there is a high FDP, it is commonly seen in patients with DIC, thromboembolic events, pulmonary embolism, DVT, anterior myocardial infarct, and fibrinolytic therapy. And the third investigation I like to do is prothrombin time. High patients seen in high prothrombin time is seen in patients with liver disease, vitamin K deficiency, factor deficiencies, DIC, and here this high prothrombin time means what is the high prothrombin time? Means the blood is taking longer to clot. The normal prothrombin time is 11 to 13.5 seconds. And the fourth one is the lupus anticoagulant level. It is around 20 to 35 GPT per unit. Now, the presence of antiphospholipid antibody level. Antiphospholipid antibody level consists of lupus anticoagulant and anticardiolipin antibody. These presence of lupus anticoagulant is predisposed for blood clot formation. So now we have come to know that what are the routine investigations we have to do when a patient comes to you with a COVID-19 infection according to their symptoms, whether they are normal, whether they have got upper respiratory tract infection, whether they got a pneumonia, and whether the pneumonia with respiratory failure or pneumonia respiratory failure in shock state, and what are the coagulation abnormalities, and what are the added investigations, coagulation factors, which we have to do to come to a conclusion. Now we come to the treatment part. Before coming to the treatment part, there was a study of 183 patients in 2020 May. And here they compared the coagulation test with people who have survived COVID-19 infection and those patients who have not survived in COVID-19 infection. Here we took the prothrombin time, APTT, fibrinogen, D-dimer, FDP, and antithrombin level. These are the tests which we do additionally for critically ill patients. And there was a comparison in that the prothrombin time normal is 11 to 13.5 seconds. Those who survived, they found that it has come up to 13.6, and those who didn't survive, it went above 15 seconds. APTT. In APTT, they found that the normal level of APTT is 30 to 40 seconds. In survivors, it was 41.2 seconds, and in non-survivors, it is 44.8 seconds. Fibrinogen level 2 to 4 per liter. In survivors, it was around 4.5, and non-survivors, it was 5.16. And D-dimer. D-dimer is a very important investigation for people who have COVID-19 infection. Normal level is less than 0.4 microgram, and in survivors, it was found to be 0.6 and above, and non-survivors, it was up to 12. Then we do the FDP level. FDP level is 1.25 to 10 mg per ml. Here the survivors was having up to 4, and those survivors, non-survivors, it went above 10. And antithrombin level normal is 80 to 120%. Those who survived, it was up to 91%, and those non-survivors, it was below 80%. So this was a comparison of the various coagulation markers and those who survived and those who not survived, showing us that these coagulation markers should be done in every patient who are critically ill, so that we will have an idea and which micro and macro thrombi. Now, finally, now we'll come to the treatment for coagulopathy in COVID-19. What treatment you like to give in a patient? Now, here also there was a lot of studies which is conducted. A study was conducted between April 2020 to February 2021. Here, various forums have come into picture. The forums, I can give you the names of the forums. Mainly the National Institute of Health, 2021 February. the International Society of Thrombosis and Hemostasis. It was conducted in May 2020. Anticoagulation Forum Interim Clinical Guidance. It was conducted in July 2020. The American College of Chest Physicians. It was conducted in June 2020. And International Society on Thrombosis and Hemostasis, which was conducted in August 2020. And finally, the National Institute for Health and Care guidelines. This was conducted. Now, in all these patients, there are all these forums. Now, all these forums, they have taken OPD patients, they have taken in-hospital patients consisting of those in the ward, those in the ICU, and those patients post-discharge. In this, they have given, for this is a study mainly, which patient to be given anticoagulation therapy. They have found that in OPD patient, anticoagulation therapy is not mentioned and none of them is given anticoagulation therapy. Okay, and it is not advised. While in hospital, it routine dose thromboprophylaxis, no routine antiplatelet therapy. So routine dose thromboprophylaxis was given to all patients who are admitted both in the hospital and in intensive care unit. Now, regarding the patients who are discharged from the hospital, they have not recommended to give any anticoagulant therapy to any patient who, after discharge from the hospital, when they go home, it is not advised anticoagulation therapy unless extended thromboprophylaxis is only considered in patients who had low risk of bleeding but high risk of venous thromboembolism as per the protocol for patients with COVID-19. Otherwise, no routine prophylaxis is given for anticoagulants is given to post-discharge patients. So with this, we have studied the various forums, and in these various forums, we have studied that OPD patients of COVID-19, anticoagulant therapy is not recommended, and in OPD and in hospital, routine thromboprophylaxis is recommended, and after discharge, the thromboprophylaxis is not recommended unless patient is not ambulant and patient has high risk of venous thromboembolism with less risk of bleed. Okay, so this much we have come into conclusion. Now the point now is what anticoagulant you will give in these patients. There are three anticoagulants. One is the unfractionated heparin, the second is the low molecular weight heparin, and the third is oral anticoagulant. Now, which we should use? Now, here also there was a study conducted. Everywhere the study is conducted and then they come to a conclusion. Here, study was by using low molecular weight heparin and unfractionated heparin. Okay, molecular weight heparin, the dose here in the study was enoxaparin, and all these patients were there in the hospital and kept for within 28 days. All these investigations was done, and the result was it was observed that the therapeutic dose of in-hospital enoxaparin showed less complications of thrombosis and early recovery compared to unfractionated heparin. So from this, they have decided that instead of unfractionated heparin, we should give low molecular weight heparin was advised to all the patients who need anticoagulation therapy. Next, once we decided that the low molecular weight heparin should be given to all these patients, then what type of anticoagulation means? What is it? You like to give a prophylactic dose or you have to give a therapeutic dose? So again, a next study was conducted on 11th March 2020 to April 31st, 2020. In this short period, within a month, The prophylactic dose of low molecular weight heparin was 0.5 milligram per kg body weight 12 hourly subcutaneously, and the dose for therapeutic dose was 1 milligram per kg 12 hourly subcutaneously. In this analysis, they took 98 patients and they've given them low molecular weight heparin in prophylactic dose and 56 patients on therapeutic dose. The study, the result was 44 of the 98 patients on prophylactic dose died and 10 out of the 56 patients in therapeutic dose died. Hence, the mortality was 6.4 higher in a prophylactic dose which was given. Now, the result was the therapeutic dose of low molecular weight heparin decreased the mortality in patients with severe COVID-19 pneumonia compared to prophylactic dose. So we prefer the therapeutic dose rather than the prophylactic dose in a patient who is admitted in a hospital and the ward or in the ICU. Now, this we have come to a conclusion which an anticoagulant to be used. Next, what is the protocol for anticoagulation in all patients with COVID-19? Number one, in non-hospitalized patients with COVID-19, there are currently no data to support the measurement of coagulation markers, and no anticoagulant is given on OPD basis. Number two, patients who are receiving anticoagulant or antiplatelet therapy for some other condition, they should continue these medications if they receive a diagnosis of COVID-19. Number three, non-hospitalized patients with COVID-19, anticoagulant antiplatelet therapy should not be initiated for the prevention of venous thromboembolism or arterial thrombosis unless the patient has got some other indication for the therapy. Number four, hospitalized non-pregnant adults with COVID-19 should receive prophylactic dose anticoagulation. Number five, all hospitalized patients with COVID-19 should not routinely be discharged from the hospital while on venous thromboembolism prophylaxis. Number six, continuing anticoagulation as per the FDA administration approved regimen for extended venous thromboembolism prophylaxis after hospital discharge can be considered for patients who had low risk of bleeding and high risk of venous thromboembolism. 7. Remote screening of the patients for DVT in COVID-19 patients. Not recommended for those who have no symptoms or signs of DVT. In a hospital, you should not go on doing the screening test for venous, like Doppler of the venous thrombosis, Doppler of the veins of the lower leg, routinely should not be done. And 8, for hospitalized patients of COVID-19 who experience rapid deterioration due to some pulmonary, cardiac, or neurological function or sudden localized loss of perfusion, peripheral perfusion, the possibility of thromboembolic disease should be evaluated. Now, a few words for protocol for gynec people that pregnancy along with COVID-19. If antithrombotic therapy is prescribed during pregnancy prior to the diagnosis of COVID-19, this therapy should be continued. Number 2, all pregnant patients hospitalized for severe COVID-19, prophylactic dose anticoagulation is recommended unless contraindicated. And number 3, like for non-pregnant patients, venous thromboembolism prophylaxis after hospital discharge is not recommended for pregnant patients unless there is a high risk of venous thromboembolism, then only it can be continued. And number 4, during labor and delivery, management will be as pregnant patients of non-COVID who require anticoagulation in pregnancy. Number 5, ultrafiltration, fractionated heparin, and low molecular weight heparin and even oral anticoagulant warfarin. These anticoagulants, they do not accumulate in the breast milk and hence do not induce anticoagulant effect in the newborn. Hence, they can be used in COVID-19 who requires venous thromboembolism prophylaxis or treatment. And number 6, using direct oral anticoagulant during pregnancy is not routinely recommended due to lack of safety data. Now, let us take the take-home messages today of this coagulopathy. COVID-19 is a highly transmissible viral infection caused by SARS-CoV-2 RNA virus and is the current cause of pandemic all over. COVID-19 virus enters the body, attaches to the endothelial surface of the blood vessels, attaches to the ACE2 receptor, releases proteins, causing various reactions leading to endothelial wall injury, resulting in virtuous triad endothelial injury, stasis of the circulation, and coagulation cascade. Study conducted in autopsy of COVID-19 patients showed micro and macro thrombi in the blood vessels. A study of coagulation abnormality in COVID-19 patients, when compared with the survivors and non-survivors we have already discussed, we found that the coagulation markers are deranged in those who have not survived compared to the survivors. And a study of the treatment for coagulation in April 2020 to February 2021 by various forums showed no anticoagulation is given for OPD patients and routine dose thromboprophylaxis given for hospitalized patients, whether he is in the ward or in the ICU. And after discharge, continuation of thromboprophylaxis is not recommended unless the patient has high risk for venous thromboembolism. All patients admitted for COVID-19 should be given therapeutic dose anticoagulation, preferably low molecular weight heparin during his stay in the hospital. And the therapeutic dose of anticoagulation, low molecular weight heparin given is 1 milligram per kg twice a day, 12 hourly subcutaneously. Now, I'd like to talk a few words on the latest update in the treatment for COVID-19. The latest update is the use of monoclonal antibodies for the treatment of COVID-19. In May 20th, 2021, FDA authorized for anti-SARS-CoV-2 virus monoclonal antibody. The name of that is Satrovimab, which was used for the treatment of non-hospitalized patients with mild to moderate COVID-19 who has high risk of progression to severe COVID-19. That means this drug called Satrovimab. This drug, Satrovimab, is given only in the initial stages as OPD patients or non-hospitalized patients who are likely to go into the second stage, moderate or severe. They are given this drug. Now, the panel also recommends another combination called Bamlanivimab and Etesivimab or Casirivimab and Imdevimab or same Sotrovimab. Sotrovimab is given to the patient who has got mild symptoms, OPD basis. They are given 500 milligram. The dose is given intramuscularly as a single dose. In May 27, 2021, FDA approved baricitinib for patients of COVID-19. Baricitinib, or you can give tocilizumab along with dexamethasone or dexamethasone plus remdesivir for treatment of patients of COVID-19 who are hospitalized, who are on high flow oxygen or on non-invasive ventilator, who has evidence of progression markers of inflammation. So now the latest treatment is monoclonal antibodies. Monoclonal antibodies is a treatment now going to come up for patients who are on mild disease of COVID-19, on OPD patients, especially whose coagulation markers or symptoms have a prediction towards severity of the COVID-19, like going into the stage 2 or stage 3. These people, they have advised monoclonal antibody treatment. And this single monoclonal antibody treatment prevents or halts the progression of the disease and uh, relieves the patients at early recovery from COVID-19 infection. Now, I like to thank all the doctors who have attended today's program and heard my personal experience in COVID-19 and the anticoagulants which were given during my hospital routine. And I still feel that today the wonder drug will be monoclonal antibody treatment, because that is coming up now slowly. Like you use monoclonal antibody for other diseases besides COVID-19, like you give it in even in cancer patients also, where this monoclonal antibody will be halt the progression of the COVID virus. Anybody likes to ask any question before we close the topic?
Thank you so much. Thank you, Dr. R.K. Modi.
Sir will ask.
Your insights. Sir, few questions are there in chat box.
Sir, you can ask the questions. Sir is ready.
Tell him to write.
It has been written, sir.
Huh?
I will show you.
Can I start?
We expect the D-dimer to be raised in other viral pneumonia.
The first question: how safe are anticoagulants?
See, how safe you, the first question is how safe anticoagulants are. Now, the thing is that the anticoagulants also, when it was compared, when it was used, the first parameters are it can also cause bleed in a patient and cause more mortality sometimes due to the bleed rather than the safety of anticoagulants. So the investigation was done. So anticoagulants are given to patients comparing with their coagulation markers, and those patients who are less likely to bleed but high chances of clot formation, they are given anticoagulants. Second question is the D-dimer to be raised in other viral pneumonia, or is it specifically for COVID? D-dimer is especially a marker for venous thromboembolism. So venous thromboembolism, the D-dimer will be raised. When the D-dimer is raised, we expect that some clot is there in the venous system of the lower limb. Then we have to further investigate whether the D-dimer, which is correlating with the VTE, that is called venous thromboembolism, and other symptoms of the patient, especially some symptoms of the patient. So that we have to decide on the basis of the Doppler study of the venous system of the lower limbs, D-dimer, plus the symptoms of the patient and if he is COVID positive or not. How
Sir,
to apply CRP level in clinical practice?
Hello.
Now,
Yes, sir. Dr. Abhijit is asking one question.
Hello.
Yes, sir. Yeah.
Yes, sir. Just I wanted to know, Dr. Abhijit here. So I just wanted to know whether this D-dimer will be raised in other viral pneumonias. This D-dimer will be raised in any venous thromboembolic embolic conditions. But will it be raised in other viral pneumonias, or it is very specific to COVID pneumonia?
What he has told. 1 second. I just
Dr. Abhijit, can you write the question in the chat box?
Yeah, I have written it down. Yeah, I have written it down.
Okay. 1 second.
So I want to ask one question. Hello, sir. Hello.
there.
Hello,
Yes,
Dr.
ma'am.
Swati here.
Yeah.
One second, ma'am. Once the questions in the chat box are over, you can ask.
Okay, okay, sir. Okay. Yeah.
Please wait, ma'am. Yeah.
What
Huh?
can we expect the D dimer to be raised in other viral pneumonia, or is it specifically for COVID-19?
No, it is specially for the COVID pneumonia because the formation of pulmonary thrombosis and embolism. For that, D dimer will be markedly raised. So I think this will be more in favor for the COVID pneumonia, not for the other conditions.
Dr. Abhijit, does it answer your question? Hello, am I audible, sir?
Abhijit, sir.
Hello.
Yes, sir.
What?
Yes, sir.
Yeah.
Yeah. I'm able to hear you. Right. I got the answer, sir.
Yeah. Thank you.
Thank you.
Yes,
Thank you,
Dr.
sir.
Swati.
Your question is
Second question.
second question. What about patients who have high D dimer and are on treatment on OPD basis? Now, any patient, whether it is COVID or non-COVID, if the D dimer is high, then you have to suspect that patient can have a venous thromboembolism risk. So you have to do a Doppler study of the venous system of the lower leg to rule out there is any thrombosis or clot in the veins of the leg. Number two, whether the symptoms the patient is having breathlessness, where the chances of pulmonary embolism is high, and the D dimer will be raised. So you have to further investigate for it whether he is COVID-19 or not.
This is from Dr. Rohit.
So we have seen patients post-COVID whose heart rate is at higher side. According to you, should we give an antihypertensive medication? Well, as you know, the heart rate, the blood pressure depends on the ratio of the heart rate to the resistance of the blood vessels. I agree with you. But if only the heart rate increases, that doesn't mean that you should give treatment. Unless the heart rate is more, you have to further investigate whether that is part of the COVID or non part of the COVID. If the heart rate normally in post-COVID patients, you can always see the heart rate is between 100 to 110 normally without any other factors involving in it. So you have to prove it whether it is part of the post-COVID, that there is tachycardia, sinus tachycardia I'm talking, or whether it is some other cause of cardiac problems.
Sir, can you
Question is
IL-6. IL-6 is called interleukin 6. There are two, IL-1 and IL-6. They are pro-inflammatory markers. These pro-inflammatory markers can be seen especially in COVID-19 infection. The more the IL-6 goes on rising, you have to do the IL-6 every week to see, or every 4 days or 5 days, you have to repeat the IL-6 in a COVID-19 patient and see if the progression goes on. If the IL-6 goes on rising and rising, it is a sign, a marker of deterioration of the patient's condition in COVID-19.
Hello.
one question
Hello,
is
Hello.
1 second. Sir, is there any chance of vaccine causing coagulation in future?
Due to vaccine, there is any coagulation. Due to vaccine, there is any coagulation. Due to vaccination.
COVID vaccine.
Vaccine. It is causing coagulation.
Achha, you are talking about after the vaccination, whether
Yes,
the coagulation takes place or not due to vaccine. Well, there is no much information yet shared by any forums regarding this post-vaccination coagulation problems. But I have seen many patients, especially now admitted under me, that patient has taken only one dose of Covishield vaccine, but after 5 days of that Covishield vaccine, he developed sudden onset of chest discomfort, profuse sweating, and ECG showed anterior wall ischemic changes, which loading dose was given to him. Later, after about an hour, the ECG changes reverted to normal. We did a angiography of the patient coronary which showed a plaque, but there is no obstruction. So finally, the diagnosis was non-obstructive coronary artery disease. But still, we could not find out whether that is part of the vaccination which has caused the immune reaction leading to changes in the ECG and the chest pain, or it is part of some other cause relating to this. So till now, there is no proof of vaccination causing coagulation disorder, but there are a lot of patients who has got some problem or the other. Especially, I got a patient who has got, after 2 doses of vaccination, patient has developed chronic diarrhea for the last 2 months, and it is watery. And in that patient, the IL-6 was 30, and the patient has got a mild fever, but otherwise, other vital symptoms were normal. And even after 2 months, after all the investigation, repeat IL-6 was 2, but still the patient has got loose stools, and the colonoscopy was done, not showing anything. The investigation for gluten sensitivity was done, which was negative, and the chest HRCT was done, which was normal, but the patient's loose motion has not subsided, nor the mild fever of episode of 100. So still we do not know that it is due to the vaccination.
Thank you.
Huh?
Yeah.
Chindan sir, no questions in the chat box.
Yeah.
All the questions are.
God. Sir, one last question is there. Sir, what's your take on the use of warfarin in COVID-19?
What is the use of warfarin in COVID-19?
Warfarin.
Yes, antiviral.
Yeah, warfarin. Now, those patients who are already on warfarin, especially patients who are on atrial fibrillation or any other condition, if they get COVID-19 infection, we should continue their previous dose of warfarin. But those patients who are not taking warfarin, and those patients, we should not recommend warfarin as an oral anticoagulant in COVID-19.
Yeah. Sir, one more question is there. After how many days after the admission, the D dimer comes to the normal?
What?
After admitting the patients, how many days the D dimer comes normal?
D dimer.
D dimer.
With,
Yes.
when you call this therapy?
D dimer, you are talking about a D dimer. How many days it will subside? Now, I think most of the patients, even after 3 months of COVID-19, after admission, after discharge, I have seen that it has come to nearly normal level. It takes around 3 months.
3 months it is, sir.
Yeah.
Hello.
Yes. Yeah. Thank you. Thank you, sir.
Okay. Okay. Thank you, sir. Okay, sir. Thank you. I'm leaving now. Thank you, sir.
Yeah, yeah. Thank you. Thank you,
Yeah,
Dr.
very
Swati.
useful lecture. Yes, sir. Thank you very much.
Thank you. Sir is saying thank you for joining.
Yes.
Yes, sir. Thank you.
Yeah. With this, I thank you all the participants for joining today's
All of you, thank you very much. This is my personal experience, which I made this topic today, not from any other book, and my personal experience and the journals I have, because I had an interest, because most of the patients who didn't survive, I have found them that they had maximum micro thrombi in the, especially in the lungs. So this, I still feel that we are still behind a lot in the treatment of COVID-19 and virus infection. So thank you all for coming over here. Thank you for watching my video. Please like, share and subscribe.